So, ladies and gentlemen, dear colleagues, on behalf of my co-chair, let me start this final session of the SCTS University on coronary artery disease, the evidence behind decision-making. So after having discussed about completeness or incompleteness of myocardial revascularization, case-based discussion, and OPCAP, we're moving to total arterial revascularization. We will hear a talk on bilateral internal mammary artery grafting, radial artery usage, can assessment of graft flow improve the success of surgical revascularization, and did we succeed in improving results of CABG? So the first talk will be given by my friend David Taggart from Oxford, who will address the question of bilateral internal mammary artery grafting. I'm sure you will say it's no good, huh, David?
Thank you, Mr. Chairman. I'd like to thank SCTS and the university in particular for the opportunity and privilege of making this presentation. I do have some conflicts of interest here. One of them is a commercial one, because I act as an advisor to a company called VGS, Vascular Graft Solutions, and I'm going to talk very briefly about one of their products. And I do actually have some shares in this company, although I've absolutely no idea what they're worth, if anything at all. But if it's as good as I think it is, then one day I'm going to send you all a postcard from the Bahamas saying, I told you it was a good idea. Right, so where are we just now in terms of CABG? If you look at the 2010 guidelines, what do they recommend just now? And I've summarised here for both CABG and PCI, the guidelines from ESC, EACTS, and from North America, the ACC, AHA. And essentially, we can divide coronary artery disease into 9 patterns of disease, 1 and 2 vessel, 3 vessel disease, and then 4 subcategories of left main. And without going through this in a terribly laborious way, if you look at CABG, what we can see that both from Europe and North America, almost all the boxes are green, meaning that it's a class 1 indication to carry out bypass grafting. If we then look at PCI and look at the ESC, ACC guidelines, we can see that most of the boxes are yellow, orange, or red. Yellow and orange means you should be cautious about doing it. Red means it's class 3, you shouldn't do it. And what you can see is that there is quite broad agreement between European and North American guidelines. And one of the key messages to take away from this today is that as we practice, for most patients with 3 vessel disease, that is 80% of them have syntax scores above 22, which means they have a class 1 indication for CABG and a class 3 indication for PCI, meaning these patients should not be stented unless they are high-risk candidates for surgery. And if you look at left main, almost 66%, two-thirds of all patients with left main fit into syntax scores above 32. Now, the story of arterial grafting for CABG began really with this landmark paper for almost now 3 decades ago, published in the New England Journal of Medicine by the Cleveland Clinic Group. And they showed that 10 years after CABG, if you put an IMA to the LAD, you significantly reduce the risk of death, MI, recurrent angina, and the need for redo surgery. And they attributed this to the fact that with an IMA, the patency rates were in excess of 95% at 10 years versus 25 to 50% for vein grafts. And this survival benefit of a mammary artery has now been shown to persist not only into the 2nd, but the 3rd decade of follow-up. And you could argue, if it wasn't for the IMA today, there probably would be no bypass grafting today, because even the most aggressive interventional cardiologists will accept that there is nothing as effective as an internal mammary artery to the LAD. Now, if we look at the 15-year rates of patency of saphenous vein grafts, they're around 30% versus over 90% for the IMA. And this is because vein grafts undergo 2 phases of remodeling. There's an early phase, which is shear-induced, which leads to dilatation of the vein. And then there's a later phase induced by increased wall tension, which leads to thickening and stiffening of the vein graft, a process we know as intimal hyperplasia. And if we compare an internal mammary artery, a radial artery, and a saphenous vein, we can see that there are differences in morphology and physiology. Morphologically, the IMA has a thin, smooth muscle media and a tight internal elastic lamina. And physiologically, the IMA produces more nitric oxide, both in basal and stimulated states, than a radial artery or a saphenous vein. Now, the difference between the IMA and vein graft bypasses is very important in terms of these endothelium-dependent relaxation factors, the most important of which is nitric oxide. Because Lucia showed in 1988 in the New England Journal that the use of an IMA resulted in superior graft patency itself, but also by eluting nitric oxide into the left anterior descending coronary artery itself, it prevented disease development in the LAD territory. And this has been shown in 5 different studies looking at progression of disease in the LAD when the LAD was grafted by IMA or saphenous vein. And in 2007, Lucia then produced another paper in Circulation showing that if you place a drug-eluting stent in the proximal LAD, this impairs re-endothelialization, it creates a prothrombotic environment, and it impairs distal endothelial function. Now, if you look at patency rates of bilateral IMA grafts, it's important to understand that there was a previous assertion that the IMA had superior patency compared to vein grafts because the IMA was placed to the left anterior descending territory, so it had better runoff than vein grafts which were placed to other coronary arteries with less favourable runoff. But I've summarised here 8 studies in the literature, all of angiographic patency of both left and right internal mammary arteries at various times from 7 days to 10 years after operation. And you can see that the patency of both left and right mammaries are always over 90%, sometimes as high as 95%, sometimes indeed as high as 100%, even out to 10 years. And what this evidence shows is quite conclusively that placing internal mammary arteries to the left-sided coronary arteries, you have equivalent patency of both the left and right internal mammary artery. And the next obvious question is, does that actually translate into a survival benefit? So we published this systematic review of studies comparing bilateral and single IMA grafts, now in 2001, so well over a decade ago. And at that time, we matched almost 4,700 patients with bilateral and 11,000 single mammaries from 7 databases. And importantly, we matched these patients for age, gender, LV function, and diabetes, because these four factors by themselves give a strong indication of the likely longevity of a patient, even independent of any knowledge of their coronary anatomy. And what we found was that the hazard ratio for death with bilateral IMA grafts was 0.8, and that translates into a number needed to treat of 13 to 16 patients to have 1 extra survivor. Now again, I would caution this was not a randomized trial, but nevertheless, it was matched on important predictive factors determining longevity. The harsh fact is, however, that even a decade after this, fewer than 10% of patients in Europe and fewer than 5% in the USA actually get bilateral IMA grafts. Now, this is an updated meta-analysis published in the Annals of Cardiothoracic Surgery last year. I'm one of the co-authors. And if you look towards the bottom, you can see that this now compares almost 20,000 bilateral IMAs and almost 60,000 single internal mammary arteries, and again showing the hazard ratio for death of 0.78, so highly statistically and clinically significant. And if we ask the question, why do so few surgeons in Western Europe or the US use bilateral IMAs? We again tried to answer this more than a decade ago. At that time, we wrote to every consultant cardiac surgeon in the UK and asked them about what they thought about the use of bilateral IMAs. 92% said there was probable or definite benefit. Over half the surgeons said that somewhere between a quarter to half of their patients would benefit. And most importantly, 2/3 of the consultants who responded said that if they were having CABG, they would want to have bilateral IMA grafts. So why did they not actually use them? Only 20% said that there was no proof of benefit, and 70% disagreed with that. But almost half of all respondents said that the use of bilateral IMAs may result in higher mortality, higher morbidity, that the procedure may take too long, and that there may be a learning curve to using 2 IMAs. Now, the last bit is definitely true. There's a learning curve to using 1 IMA, there's a learning curve to using 2 IMAs, there's a learning curve to playing tennis or golf. So the last part of this is true, but are any of these other statements true? To try and advance this, we performed this randomized trial. At the time, it was the largest trial ever done in cardiac surgery. There were 3,100 patients randomized to single or bilateral IMA grafts. Note that the primary outcome is 10-year survival, so we won't have this till 2018. This trial was conducted by 67 surgeons in 28 centres in 7 countries. You can see the different flags at the top of the slide. The key points to take away from this, the 30-day mortality was 1.2%, the 1-year mortality 2.4%, and the 1-year incidence of stroke, MI, and repeat revascularization all under 2%. And there will be an interim analysis of the 5-year outcomes published later this year. But again, I make the point, only 5% of patients in the USA and 10% in Europe received bilateral IMA grafts. Now, if we look at the ART trial in a bit more detail, we can see that 82% of the patients received 3 or 4 coronary bypass grafts. And what was the difference between using a single and bilateral IMA? Well, using a second IMA added 23 minutes to the operative procedure, which was between 3 and 4 hours. It added an hour and a half to ventilation, on a mean of about 16 hours of ventilation. It added 3 hours of ITU stay, on what was basically somewhere almost 40 hours, and added an extra half day in hospital, but with no difference in re-exploration, blood transfusion, balloon pumps, or renal support. If you look at the 30-day outcomes, I've already mentioned these. No difference in mortality, stroke, MI, repeat revascularization, but what we did see was an increased incidence of wound reconstruction from 0.6% in the single group to 1.9% in the bilateral group. So that's an absolute increase of 1.3%. If we look at 1-year outcomes in terms of mortality, stroke, MI, repeat revascularization, no difference in these groups. Now, in terms of the increased incidence of wound reconstruction of 1.3%, that translates into a number needed to harm of 7 to 8 patients. Excuse me. However, I would make the following point. ART was fairly liberal in its use of bilateral IMAs in diabetic patients. Almost 30% of patients had diabetes. And although we're doing an analysis just now of the exact factors that predispose to wound breakdown, I can tell you what they are, because you already all in this audience know what they are. And it's the presence of diabetes, not diabetes itself, but patients who are obese and diabetic. And if you avoid using 2 mammary arteries in that group, you can almost reduce the incidence of wound reconstruction to identical in the single mammary group. And why does this happen in diabetic patients? This is a sternal perfusion scan of a patient who had both mammary arteries harvested. The left mammary was harvested with a skeletonized fashion, the right mammary with a pedicled fashion, and you can see that there's significant reduction in perfusion in the right side of the sternum, and these reductions in sternal perfusion are magnified in diabetic patients. Now, there has been this meta-analysis of bilateral ITA harvest and deep sternal wound infection in diabetics, and what it basically shows is that if you skeletonize both mammary arteries, there is no difference in deep sternal wound infection between single and bilateral IMA grafting, whereas if you harvest the mammaries as pedicled, you do see a significant increase in deep wound sternal infection. Now, I have to say, although this has been published, I have reservations about this because it's been my experience of using 2 mammary arteries for over 15 years, that even skeletonizing them in obese diabetics, I do think there is still an increased incidence of deep sternal wound infection, but this is what has been reported in the literature. Now, if we look at the patency of the right mammary out to 20 years, this is a paper by James Tatoulis, colleague of Brian Buxton, published in Current Opinion in Cardiology in 2011. And the first diagram shows both the patency of the left and the right mammary artery to the LAD at 10 years. And you can see the patency of both graphs identical at 95%. The second graph shows the patency of left and right mammary to the circumflex system. It's slightly lower at 90%, but it's still the same for left and right mammary. And as they follow patients out to 20 years of follow-up looking at the right mammary artery, the patency of that right mammary remains in excess of 95% at 20 years. So these are the kind of data that you would never see with vein grafts. Does this translate into a benefit at longer term follow-up? Well, the best evidence that we have in the absence of randomized trials is that it still does. This is a propensity matched registry of almost 2,500 patients in each group with single and bilateral IMA grafts, showing that the 15-year survival is strongly positive in favour of bilateral IMA grafts, as is the 25-year survival. This is another paper from Grau, published in European Journal of Cardiothoracic Surgery, looking at almost 2,000 patients, propensity matched for single and bilateral IMA grafts, again showing a significant survival advantage for bilateral IMA grafts at 15 years. This is a 30-year follow-up of propensity score matched diabetic patients with single or bilateral IMA grafts, again showing that the median survival is extended by 4 years in patients with bilateral IMA grafts. Now, apart from the potential survival advantages of bilateral IMA grafts, there is also the potential to reduce significantly the risk of stroke. And we alluded to this in the previous study, the previous session on off-pump surgery. So if you do a conventional CABG with cardiopulmonary bypass, there are 4 manoeuvres, and 3 of those are obligate manoeuvres which involve manipulation of the ascending aorta. If you do off-pump surgery with IMA and vein grafts, then the only aortic manipulation is attachment of the vein graft to the aorta. But if you do composite arterial grafts based on the IMA, then you can effectively eliminate any manipulation of the aorta and significantly reduce the risk of stroke. And this was shown in this meta-analysis of almost 11,000 patients from 8 studies, showing that if you do a true no-touch aortic technique, then the relative risk of stroke is reduced to 0.46. And note what that tells you. It doesn't eliminate stroke completely. And the reason for that is if you look at stroke after coronary bypass grafting, only 50% of those strokes occur in direct relation to the operation. About 50% occur day 2 to day 4 after the operation, and you can speculate as to why that might be. But this is why, even if you don't touch the aorta, you may still have strokes after cardiac surgery, but not related to aortic manipulation. So in the last few slides, I just want to talk about briefly this stent. It's called the Fluent External Stent for saphenous vein grafts. I have already declared my conflicts of interest, but I think this is a potentially important device because despite the benefit of arterial grafts, 80% of all bypass grafts put in the heart are still vein grafts. So this stent is a cobalt chromium alloy. It has both radial elasticity, which means it's kink and crush resistant. It has axial plasticity, which means you can stretch it from an initial length of 3 centimeters to 20 centimeters to cover the whole length of the vein graft. And it maintains its in-situ configuration without fixation. So what does this mechanical structure achieve biologically? It reduces the diameter of the vein graft by around 10%. It reduces luminal irregularities and flow discrepancies. It reduces wall tension and it reduces size mismatch between the vein graft and the native coronary artery, and it prevents vein dilatation post-implantation. It takes less than a minute to implant this stent, and it requires no other change in your technique. And I just show you here 3 examples of patients. So we've done a randomized trial of 30 patients. All have undergone 1-year angiography follow-up, and the results of this are being submitted to circulation. But if you look at the unsupported vein grafts in the top and compare them to the supported vein grafts in the diagrams below, the thing that strikes you immediately is that the unsupported vein grafts, even at 1 year, you can already see quite marked luminal irregularities in them. In contrast, if you look at the supported vein grafts, they look more like IMA grafts. And I can tell you, In these patients, they all underwent IVUS and OCT, and we see a highly significant reduction in intimal hyperplasia even at 1 year. And this has been the first demonstration of a mechanical device, or indeed no pharmacological agent has yet been shown to reduce intimal hyperplasia. So to summarise and conclude, the strong angiographic evidence of over 95% patency of both IMAs at 20 years. The ART study shows that the use of BIMA is feasible and safe for most CABG patients. The use of BIMA does not increase 30-day or 1-year mortality, duration of post-op stay, the risk of stroke, MI, or repeat revascularization. The use of BIMA, however, does result in a slight increase in the risk of sternal wound reconstruction by 1.3%. But as I said, this really only applies to the obese diabetic patients. And you can reduce this with a skeletonization technique. There's a meta-analysis and 3 large propensity match registries showing benefits of BIMA extending over a decade and indeed now out to over 25 years of follow-up. I haven't discussed this today because this was meant to be in the next talk. The radial artery produces better long-term patency than saphenous vein grafts. Composite arterial grafts with a no-touch aortic technique does reduce the risk of stroke. And as we said in the last session, for most patients undergoing CABG, the use of bilateral IMA grafts is more important than whether surgery is performed on or off pump. And my very final slide is we do run this masterclass twice a year on every aspect of full 2-day course on all practical aspects of arterial revascularization. The next one is this weekend, but it's probably a bit late. On that point, I'm going to conclude my talk. I'd like to thank the organisers again for the privilege of making this presentation, and you, the audience, for your attention. Thank you.